Your diabetic patient with renal insufficiency presents with abdominal pain. The imaging test of choice is a CT with contrast. Do you proceed with the test? What can you do to help protect this patient's kidneys from the impending contrast load? You're listening to ReachMD, XM 157, the channel for medical professionals. I'm Dr. Lee Freedman, your host, and this is the Clinicians Roundtable. Our guest is Dr. Michael Rudnick, Associate Professor of Medicine at the University of Pennsylvania Medical School in Philadelphia. Thank you so much for being with us, Dr. Rudnick.
It's a pleasure to be with you, Lee.
How can we help to protect our patients with renal insufficiency who need to have a contrast study?
Oh, that's a great question. Let me first start out by saying that unlike some other forms of acute kidney injury, we know when the toxic exposure of dye is going to occur. In comparison, let's say somebody's in a serious accident where they develop rhabdomyolysis. That's an unpredictable kind of thing. Somebody goes to surgery or has a cardiac event where they become ischemic and they develop acute kidney injury. That's also kind of unpredictable. So contrast is actually unique in the sense that we know exactly when it's going to be administered, and that lends itself to using prophylactic tools. We spoke, I think, on a previous episode about who's at risk for this, and in your introduction you certainly hit it right on the head. Patients with renal insufficiency are at risk. And the point that I just want to expand on is that if you have renal insufficiency and diabetes, your risk dramatically increases. But what's interesting is that diabetes by itself, without renal insufficiency, is not really an increased risk. So the diabetics are only acts as a risk factor in the presence of renal insufficiency, not with normal renal function. So there are a number of steps that we can take. Some of them are related to the procedure itself. Some of them are not related to the procedure, to try and prevent this from occurring. Let's talk about just some of the procedural things that one can do to prevent this from occurring. One, of course, is to use the smallest amount of contrast media possible. Now, people often say, well, is there a value or an amount of contrast that I can give that if I stay below, I won't have this, and if I go above, I have a risk of having it? It'd be nice if it was that simple,
right?
But it's not. And let me give you an example. You could take somebody who has pretty good kidneys, no history of diabetes, and give them 500 mLs, which is a huge amount, or maybe 400 mLs of contrast, and they're not going to develop acute renal failure. You can take an insulin-dependent diabetic, a type 1 diabetic, with a creatinine of 5, which is, pretty high, and you can give them 30 mLs of contrast, and they will develop acute renal failure. But there are formula people have proposed that, do seem to suggest that if you can stay below the value of the volume predicted by the formula is based on, of course, the serum creatinine and what volume you should give, that you have less risk of developing acute renal failure than if you go above it. To my mind, I'm not sure the value of that. I think the value is just to use the least amount of contrast you can. Just because you're below the level by the formula doesn't mean that you have license to really use more. You just use the absolute minimum necessary to get the clinical job done.
And that should be likely communicated by the ordering physician to the radiology center or hospital?
Well, the radiologist or the cardiologist who's doing the study, are well aware of that. And if that's what's communicated to them, and they should be aware before they start that they've got a high-risk patient, they should certainly do that. So I want to then tell you about another procedure thing, which is the choice of contrast. Compared to the 1970s and the 1960s, contrast agents in the 1980s and subsequently are a little bit different physiochemically. These contrast agents are all composed of these benzene rings that each contain 3 iodine atoms, but the osmolality, the number of particles in solution, has dramatically decreased with modern-day contrast agents compared to contrast agents in the 1960s and 1970s. The modern-day contrast agents are often referred to in literature as low-osmolar contrast media or non-ionic contrast media, in contrast to the earlier contrast media, which is high-osmolar ionic, which basically are historical right now. But they weren't historical, at the end of the 1970s or 1980s, and in the 1980s when these newer agents came out, they were actually much more costly than the older agents, and there was a lot of debate. And I was the lead author of actually a study that recruited 1,200 patients from across the United States and was the initial study to definitively show that these newer agents cause less nephrotoxicity than the older agents.
Probably a cost-effective in that sense.
Probably, but we never did that analysis, but it's a good point. The reason I tell you about this is that in the past decade, there's been yet a third generation of contrast agents, which has a slightly different physical configuration, but the end result is that the number of particles has been able to be reduced even further, yet still deliver the same amount of iodine, and those are called isoosmolar contrast agents, and they have the same osmolality as normal plasma. Needless to say, they are significantly more expensive, but the idea was that if the low osmolar contrasts were less toxic than the high osmolar contrasts, then maybe these isoosmolar contrasts, which have osmolalities that are even lower, are less toxic than the low osmolar contrast. And the initial study that was done looking at this in Sweden, that was published in the New England Journal of Medicine, called the Nephropathy study, actually showed a dramatic benefit. And for years, people were preferentially using this isoosmolar contrast. Other manufacturers of low osmolar contrast have designed other studies comparing their product with it's only one isoosmolar contrast. It's called Visipake, and compared their product with that. And the results have not been consistently that Visipake is less toxic than the others. In some cases, the toxicity is about the same. So, this is an area of controversy. Again, the radiologists and the cardiologists should be familiar with this in terms of their selection. I think that in many cases they may choose to go with either a low osmolar contrast that's been shown to have a low incidence of toxicity, or to go with the more expensive isoosmolar contrast. But in any case, they do try and be selective in the contrast media they use in the hopes of preventing this.
If you've just joined us, you're listening to ReachMD, XM 157, the channel for medical professionals. I'm Dr. Lee Freedman, and I'm discussing how to protect the kidneys from contrast loads with Dr. Michael Rudnick from the University of Pennsylvania. Dr. Rudnick, in addition to dose and type of contrast, I imagine hydration has to play a key role.
That's right, Lee. Actually, the single greatest unanimity of what we can do to try and prevent this is hydration. And the idea here is pretty simple. We understand that the most likely mechanism of renal failure in these patients is somehow the contrast agents cause a decreased blood flow to the kidney and makes them susceptible to injury. And we know that in animal models, if they are salt depleted, this risk of injury is dramatically increased. So for years now, we have used various forms of hydration. And we've seen an evolution in this. We went from using half normal saline at a rate of around 1 cc per kilogram per hour for 24 hours, 12 before and 12 after, to much shorter periods of hydration. And the reason for that transition is, as you're well aware, even today, arteriograms and cardiac catheterizations are being done in increasing numbers as outpatients. Mm-hmm. And so it's very difficult with third-party payers to have somebody in the hospital 24 hours, even if they are at risk, for hydration. And even if third-party payers would be willing to do that, the patients are not willing to do that.
Right.
So by default, have begun to give fluids for a few hours, 4 to 6 hours before, 4 to 6 hours afterward, without any real proof that that's as good or not as good as the longer periods of hydration. Then what happened is, just more recently in the last few years with an article that appeared in JAMA by a guy by the name of Greg Merton, he went ahead and randomized his patients to receive sodium bicarbonate at a concentration where the sodium in the fluid would be 150 milliequivalents, very similar to the way normal saline would be, versus normal saline. And he showed that if you gave the sodium bicarbonate, that there was even a lower incidence of acute renal failure compared to if you gave the sodium chloride. And the nice thing about his study is that he gave the sodium bicarbonate at a dose of 3 cc's per kilogram per hour for just the first hour, mm-hmm. So they don't have to come in a long time ahead of time. Then they continued it for, 4 to 6 hours, after the study. Now, no one quite knows for sure why this works or may work. I think it'd be more accurate. It has to do with the alkalinization may decrease the formation of something called oxygen-free radicals, which prove to be toxic to the tissues of the kidney. Mm-hmm. But what's happened is, and I just want to caution you and your listeners, is that like many things in life, the first study or two look so good it's almost hard to believe that it's true. And then as additional studies are done, you realize that it's not true. But there are now at least 6 to 10 other studies that are ongoing or that have just been completed comparing sodium bicarbonate to sodium chloride. Although I could be wrong on this, I would not be surprised at all if some of these studies could not show a benefit, leaving, again, the question of what is the ideal hydration.
So some kind of hydration, maybe sodium bicarbonate, could be better than normal saline, but the jury's still out.
The jury is still out. There are other things that have been tried to prevent, contrast nephropathy, and some of them have proven that they just don't work.
Mm-hmm.
For example, mannitol has been shown historically not to work. There is something called phenoldiprem, which is a dopamine-type drug that dilates the arteries in the kidney. That doesn't work. The atrial natriuretic factor, that doesn't work. But one of the more simpler things that has been suggested to be effective is something called N-acetylcysteine, or the shorthand version of his NAC.
Uh-huh.
And N-acetylcysteine is the trade name is Mucomyst, and so people know it for loosening secretions in the bronchial tree. And there was an article that appeared in the I guess just around 2000, 2001 by a Professor Teppel in the New England Journal of Medicine, where he took patients who were at risk for developing contrast nephropathy, and one group got placebo and the other group got this acetylcysteine as a tablet, 600 milligrams twice a day starting the day before, and then 2 more times the day of the study. And there was a dramatic reduction. It went there's a 25% incidence of acute renal failure in the group that got the placebo versus a 3% incidence in the group that got the that got the acetylcysteine.
Mm-hmm.
So people went pretty wild about this, because it was such a dramatic improvement, number one. Number two, it was really it's very inexpensive. It's about $17 for 4 doses. Number three, when you take it orally, there's almost no side effects other than, in this country, we don't have it in a pill, so it's given as a liquid, and it's got a very pungent smell and taste to it, so it's usually mixed with syrup, like Coke syrup or orange juice, etc. Other than that, there's not much risk to it. Now, subsequently, despite the dramatic first report on this, over the next 5 to 8 years, there have been another 20 studies that have come out, many of them not showing a benefit. And when you have studies, some showing a benefit, some not showing a benefit, they do this statistical analysis called a meta-analysis. And the most recent meta-analysis do raise the question of whether there's any effect. That hasn't stopped it being used because it's such a low-risk thing, and since the jury's out on it, many physicians still use acetylcysteine.
Well, I want to thank Dr. Michael Rudnick, who has been our guest as we've been discussing ways to prevent contrast-induced nephropathy. He's pointed out to us that the dose and the type of contrast is important. Hydration is critically important. And then there are several agents that have been tried and have been shown not to be effective. And acetylcysteine, because it is benign and might be effective, is one that we are still using fairly widely. This is Dr. Lee Freedman, your host of the Clinicians Roundtable. You've been listening to ReachMD, XM 157, the channel for medical professionals. Thank you for listening.